Thanks, everyone, for joining us for this episode of the NIC Chats podcast. I'm Lisa McCracken, Head of Research and Analytics with NIC. So glad that you are joining us today. I'm going to introduce our guest panelist here in a second, but I do want to thank our sponsor, who is Sage. And without their sponsorship of this webinar series, which we're touching on value-based care from three different perspectives, without their sponsorship and support, it would not be possible. And in case you want to check them out, they are at hellosage.com. What they do in terms of their solution, they empower senior living communities with real-time data, proactive insights, and intelligent care coordination, which transforms operations, enhances resident outcomes, and helps teams make faster, smarter decisions every day. So thank you to Sage. And I know Anne and I will be probably touching on a couple of those things. So welcome, Anne, from ATI Advisory, the CEO and I believe founder of ATI. I'll let you introduce yourself because you'll do a better job of it than me, just so people have background in the organization and a little bit about you, Anne.
Yeah, sure. Thank you. Thanks for having me and thank you for doing the series. My name is Anne Tumlinson. I am the CEO and founder of ATI Advisory, which is a professional services research firm that works to make care work better for everybody. But I would say our differentiator and focus is on the population that has complex care needs, and real older adults is my area of expertise in particular. So I've had a lot of wonderful opportunities to work with senior living operators, and in particular around how the value-based care programs and the Medicare Advantage program can help, essentially pay for, finance, facilitate, um, bringing and integrating healthcare and care management on site for residents.
Mhm. It's been fun to watch your organization grow over the years. I feel like I'm always thinking about new folks joining and this
Yeah.
expert and that expert. What are you guys up to in terms of team?
Yeah, thank you. We are up to about 50 people now. Yeah, I know. And I do want to just say that NIC was one of my very first clients when I started the firm. Coming out, my background was I worked at Avalier Health, another consulting firm, for many, many years, where I led the post-acute and long-term care practice group, and also worked to build and launch a business intelligence solution based on Medicare claims data, and got to know a lot of the skilled nursing facility post-acute care providers in who have been very active in the community, and so NIC community. And so when I went over to launch my own enterprise, I obviously knew a lot of them, and I knew NIC, and I knew Bob Kramer, and I just was very fortunate to have the opportunity to work on, I think, kind of early days of thinking about the role of senior living and skilled nursing facilities within the context of value-based care, and just the many opportunities that that provides.
Yeah. And I do feel like we've been talking about it for a while, but yet I would observe people are still in very different places. I think that's one of the reasons why we're doing this series is joke, we often sometimes talk about in people are the first inning, the baseball, scenario. There's still some people picking out their uniforms too. So I would observe, I think we've got folks in very different places. But the exciting thing for us is I think we're at a really unique time right now. And I do want to talk about some of the stuff that came out in recent weeks from the new administration. And I know you guys are all on top of that, but let's step back first. And if you were to describe to someone, really 101, throw a little 201 in there, that's okay, of what value-based care means in the senior living care sector, of somebody trying to understand it, how would you break that down? Because it comes in a lot of different forms and shapes and sizes, and
Yeah.
can be very intimidating for a lot of folks, to be honest.
Well, it's a phrase that's just thrown around a lot of the
Correct.
time, and it is really used to encompass a very wide variety of things.
Mhm.
So what I always encourage people to do is to start small. And what I mean by that is just think about your own, like, let's just back up. Think about your own healthcare. Think about how you interact with the healthcare delivery system. You go to the physician's office, and then they bill your insurance company for a visit. You go to the hospital, bills for a hospital stay. So essentially, where our entire healthcare delivery system works and our financing system works is that we pay on units of service. That's it. More units of service, more payment. Value-based care in its essence is really changing that paradigm to pay instead for the outcome of the service as opposed to the unit of service itself.
Mhm.
And the reason it's hard, really hard, because we have to be able to actually measure and report on those outcomes. We have to know what
Right.
is value in order to be able to pay for it. So, in its essence, that's what value-based care is.
Right.
In the context of senior living, um, and maybe actually before I go there, let me just say that's value-based care. Then there's value-based payment, and that is how you construct that payment in order to get to that higher value outcome that you want from the service delivery. And kind of the easiest way to think about it is that if you're not going to pay for a unit of service and you want to reward the outcome, on some level, what you want to do is say to the provider of the care, hey, I'm going to pay you some money and I'm going to pay you more if the outcome is better. I'm going to pay you less if the outcome is worse. In that scenario, what is happening is that the provider is taking risk, what we call
Mhm.
risk. And there are lots of different types of risk, but I think for the purposes of this conversation, one of the easiest ways to understand it is like insurance risk, right? We're
Right.
saying to them, look, this needs to cost no more than X and deliver Y outcomes. And if it doesn't, then you get less money for it, or you lose money as a result. So it's important. One of the most important concepts here is that it is asking the provider to take the risk, not an insurance company.
Mhm.
Managed care is, I guess you could argue, a form of value-based care, but it's really not. Insurance companies manage risk. They don't manage care. And what we know to be true is that the only way you can get value out of care delivery is if you ask the providers, if you change the incentives in terms of how you're paying the providers. So
Right.
in the context of senior living, what we're doing is we're saying we have all of these people who are using a lot of units of service in healthcare. It's low value because it's completely disconnected from anything else that's happening in their care as individuals who need a lot of support around function and cognition. And what we want to do is introduce a way of paying for healthcare for those individuals that changes the value proposition for them. And the
There's
senior living is a great place to do it because you have scale. Yes. Scale is one of the most important enablers of value-based care because you need to be able to, you need, well, scale is important in everything. But it's
so about like what kind of scale we talking about? Because that does come up often, Anne.
Mhm.
So like how big is big enough? And it probably depends on what we're sort of talking about, right? But I mean, because there's scale and there's concentrated scale, and that does come up often, but it can be achieved through partnerships and collaborations too.
Oh, totally.
But if you could talk a little bit about that scale piece a little bit.
Absolutely. So I think maybe I'm going to talk about kind of like operational risk
Okay.
for a minute instead of financial risk. And operational risk is, you know, r- assuming that we are doing something different with the delivery of healthcare. One building. Let me just paint a different picture. Imagine nurse practitioners in cars driving to individual homes. That is not scale.
Inefficient.
Right, right. That is from an operational standpoint, really challenging from a scale perspective. If that nurse practitioner is now driving to a building where there are 50 people, um, yeah, that is a much better sort of operational scale. That's kind of the first level. That's the first, and why probably many, many senior living operators who might be listening to this or, active in that NIC community probably have experienced, this is why the home health agencies, the hospice agencies, the physician groups, others, like they want access to your building because they can come in and deliver what would otherwise be, a very operationally inefficient service at much higher scale and concentration. It's operationally efficient and it's better for sales. So that is like first and foremost. I think when you move into the realm where um you're beginning to layer on top of that some degree of financial and clinical risk. So we need to get a hospitalization rate that is at a certain level, and we need to be able to immunize at a certain level, or like we have all these metrics that kind of determine value. Um, ultimately you're in insurance risk and you're talking about, the law of large numbers. It's math. Now, thing is, not to get too wonky, but the more control that you have, the less big numbers you need. So the reason why an ACO is like requirement is like for 5,000 people, it's because they're all living all over the place and you don't even know who's in your ACO. And it's very hard to get a handle on it. Inside senior living, you have a lot of control. Inside a nursing home, you have a ton of control. Right. That's why iSNPs, if people have heard of those, or the ACOs in nursing home setting do very well because, that's a very controlled, really medicalized environment. It gets harder in senior living, but it's still a lot more controlled. Right. Just like, you don't need as many large numbers. Like if you're familiar with the program for all-inclusive care for the elderly PACE, like a PACE center at most will be 300 people, right? And they're taking full risk for all spending, insurance risk on Medicare and Medicaid, and they do very well. Of course, payment rates are also quite high. So that helps.
Right.
But
Yeah. Yeah.
but basically, I think if you're an operator that has made a decision that you want to go at risk from an insurance perspective for the healthcare of your residents, you will need more than one building. That's where we see these consortiums like the Perennial Consortium and others, form partnerships because what they're doing is essentially adding numbers, right, to the risk pool, if you will.
Right. Right.
But if you don't want to do that, there are a lot of other options. There's so many wonderful enablers and partners. I mean, it's just a very exciting time. I went to the NIC Spring Conference, uh, and I just got back from LTC 100, a Lincoln Healthcare event, and I'm just so impressed and excited by the kind of the robustness of the market to bring solutions. I think if this is something that you want to do, and we can talk about the why in a minute, but like there's a lot of really great choices.
Yeah.
Partners.
Yeah. Now, I definitely think that we have evolved without a doubt, and there's more conversation than ever about it. And I appreciate that you separated the value-based care from the payment, because to me, when I look at the systems or whatever you maybe call it, or however you structure the care piece to ensure there's positive outcomes and so forth, that's just a better way of I say doing business, but providing for, just a better quality of life for the resident, higher resident satisfaction. There's a lot of secondary benefits outside of the payment piece, but I think you've got to have all of that in order and like your ducks in a row to be ready to enter into the payment piece of it. I mean, it's not like you just flip the switch and say, okay, we're all on board here. But I do think you mentioned the why. I really think that that's important to say. Okay, what's the so what here? Like, why should I care about this? Is this the flavor of the month or the year? Or okay, CMS wants it, but like, what's in it for me? Is it like if you don't, you're going to be in trouble down the road? Can you paint that picture and the compelling why
Yeah.
people need to pay attention.
Yeah. Well, and I think it's what I had learned over the last 2 years is that, um, particularly going through COVID with this industry and everything, is that it's been a tough sell.
Mm.
And in part because the the business of value-based care and the business of healthcare are really very different from what most operators are doing on a daily basis. However, um, the consumer, the resident, and their family are increasingly uh, asking or requiring of their whatever their solution is going to be that it have the features that enable a much better sort of overall holistic care management experience.
I
So
agree.
maybe putting just a finer point on it, I mean, not to sound like, uh, you know, um, I feel like I'm echoing Bob Kramer right now, but,
I
um,
might do that sometimes too.
which is a good thing, which
Not
is a
like
good thing.
dogs.
It's a very good thing, but the adult daughter or son does not wanna spend all their time at the emergency room.
Sure.
And the only way I mean, value-based care and value-based payment are the mechanisms to finance that the care management and the healthcare delivery inside of that building for those residents. It goes together really well.
Mm.
And, I think if you want to take it a step further, you could say, oh, this gives you, the senior living community, the opportunity to get paid for some of the value that you're already delivering. I think if you want to finance programs that your residents need around medication management, care management, on-site primary care, like they need those things. That's a much better quality. So just a much better consumer experience. And it's an expectation increasingly of the consumer and their family. The good news is that it's like there's so many ways to get that delivered and paid for in your
Mhm.
building. Like
Mhm.
you could kind of go out to the market and pick and choose how you want to
Yes.
do it.
Right.
Um,
Right.
I think and I will just put myself in this bucket where we ran into some challenges was I'll just say I was trying to make a financial case to senior living. Like you should do this because there's a lot of savings here and you should be, like if we can reduce ER rates or hospitalization rates, then you can reap
Mhm.
that reward and like there's so much value that these primary care groups are getting from being in your building and you should get paid for that. And the fact of the matter is like, that just wasn't compelling. I think of a case on pure
Mhm.
financial terms, but I still remain convinced that ultimately this is what the residents really need and want. And more importantly, there's a lot of ways to do it now that are pretty low
Right.
risk, low lift.
Right.
Still
Right.
have some financial upside.
Yeah, I think the options definitely. I mean, that's one of the nice things that there's more ways to participate and be engaged than in the past. So before we get into sort of some of the stuff that's been rolled out recently, I do want to have you talk a little bit about where this does come into play outside of skilled nursing. I think skilled nursing is the obvious one and the obvious place. And again, you definitely have that more control over that group and they have the highest, acuity and chronic health needs. But I mean, we've done that work with NORC at the University of Chicago, and we looked at the settings outside of the nursing to say, these individuals who often have many chronic health conditions, the assisted living, memory care, even independent living, we know, do, and that there are things that there's value that we are providing to those individuals that helps keep them out of the hospital, keeps them living longer and so forth. So if I'm someone that doesn't have skilled nursing, what's this mean for me? I mean, is this the primary care play with some of my residents and partnering on that front? And I mean, what's this mean for me if I'm not in skilled nursing?
Much. Yeah. I mean, I think it's the way I look at it is like, you know, your it, what it means is you can bring healthcare home for your residents. It's not about medicalizing the setting. It's quite the opposite. It's about competing with the community where healthcare at home is becoming an increasingly used. So, I can get, if I live in Pittsburgh right now and I'm in the Highmark Health Plan, I can get SNP at home when I leave the hospital. I can get, you know, like a white, like if I live in Richmond, I can get, at home harmony. They have like a traveling, advanced practice nurse set up with telehealth and remote patient monitoring. And so these models are developing in real time all over the place for people who live in the community. So in a way, it's like what it's there's, as I said before, the opportunity for senior living is l- l- like really leveling up what it is that you do and you offer to residents so that it competes with the best of what they could get even in their home. And I do worry about the industry falling behind.
So isn't that interesting, falling behind what residents can get in their home?
Yes. Like you
That's
definitely want to be better
that's
than home. Right. And I mean, I think as long as we in the industry are taking advantage of our scale and sort of the business overlay to enable healthcare at home, we've created a whole nother value proposition for our future resident that is harder to deliver at scale at home. If we don't, I think we get kind of outcompeted over time because of technology, AI, digital health and things like that.
Yeah, it is interesting when I think back about what some of that value proposition has been, even in years past, about, oh, hospitality on demand, we can provide transportation or this and that. When we live in this sort of Uberized on demand economy. So, I can get stuff delivered, I can get stuff, people to take me somewhere and this and that. Now, the socialization piece isn't in there, but I agree. It's very interesting to think about it that way, the pace of what is happening, the evolution in your home versus how quickly are we as a sector keeping up with that. I mean,
Yeah.
it's a very interesting thing to think about.
And
Uh,
you're supercharging the value of the healthcare because of what you already do. Right. So you have that socialization in place. You have the long-term care pharmacy in place, or, you have these pieces, but you're bringing it all together and supercharging that. It's like a value multiplier when you bring the healthcare on site to all of the things that you're already doing.
yeah. So I'd love for you to comment on when you see senior living and care organizations, and whether it's CCRC, a nursing home, a memory care community, when you see them getting traction in this space, doing things well, are there certain common elements of success or attributes that you have, that they have, where you might say they really devoted resources to this or invested in this? I mean, are the common characteristics that we see that you see among them?
Yeah. You know, I think the probably it's gonna sound very basic, but this isn't you have to just decide that you're going to be a good partner to whomever you're working with. So in other words, you do have to align around the business goals. So if you've chosen a partner and, you know, everyone has agreed on kind of the overarching goals, then you have to commit to whatever kinds of change management that you have to do on site in order to make it clear that this is a priority in your organization. Like that's it.
Mhm.
Executive directors have to be bought in.
Yeah.
Your on-site staff have to be bought in. They have to be, and your partner has to know how to work with them and make it work for. So the- it's really, I mean, the hardest part in all of this is just that on the ground integration.
Right.
Because in order for this to work, your residents have to sign up. for whatever it is, whether it's a primary care physician or whether it's a Medicare Advantage plan or it's both or however it's working in your organization. And there are many different flavors. You, you have to, it won't work if the organization's not committed and the people on the ground level are well integrated with the partner in alignment with the common goal. So that's hard work. That's really the hardest work. Everything else is simple, but that piece is really quite challenging. And like if the protocol is you don't call the ambulance right away anymore, or like you have to kind of be a
Change management.
yeah. So it's like having good quality to begin with and being ready to partner well and to do the change management and to adhere to some of the kind of care processes that need to be in place. But it's very doable. But it does require some change.
Yeah, and I would think grit is part of that change because, sometimes you take us, 2 steps forward, 1 step back, or we pivot, we change. But if you have the right partner, you can work through that stuff together. So I think about grit and I think about patience, because not all this happens quickly and it depends. It's sometimes if you're in this model and you're getting upside risk, or you might have to wait a long time to get that upside risk. That payment and so forth out of the government or whatever. Um, so I want to spend a few minutes here. It's about the last 5 minutes of our time, getting your take on where we are now, because there's obviously been a lot happening quickly out of the current administration for the good or for the bad. But there has been a new strategic vision rolled out by CMMI. And I think I'm not the expert in this. You are certainly more than I am, but I think that many of us looked at that and saw this is actually pretty promising. And I think this reinforces that we have the opportunity for a seat at the table. So can you just sort of recap where you see some of the opportunity right now with the new administration, what you saw emphasized?
Yes. Yeah. I'd be happy to. I'd be happy to. So it's a pretty broad stroke strategy, and some of the concepts are very similar to what we've seen in the past, but there are a few key differences, and there's some breadcrumbs, as you might put it, or signals in the text that are really new and different and exciting to me. And I've never seen a Center for Innovation. They call themselves the Innovation Center now instead of CMMI. Explicitly call out caregivers in their strategy, along with, I've never seen the words functional decline and cognitive decline, function and cognition. I've never seen those used in a strategy that could be promulgated by, like at the beginning of an administration, to say, like, this is something that we're going to be very focused on going forward. And in particular, like, even in-home support services were mentioned. So I think, it remains to be seen what the details of any kind of models that'll be coming out will look like. I think it's very notable that the guide model, the dementia model, was not discontinued from the previous administration. I think that, you know, I I think we could see something very creative and kind of maybe even similar to the guide model coming out, to help meet the needs of individuals and Medicare beneficiaries who have cognitive and functional decline, their family caregivers. I But there was a couple other signals in there that I think are important clues. One was the word prevention. And what I loved about it was that we often talk, like, we're always talking about how we're serving people who have already experienced pretty severe functional decline, as opposed to, like, what do we do to intervene in that trajectory of functional decline, like in the earlier stages, to help delay and prevent decline, to prevent the more expensive spells of morbidity towards the end of life. And I've always felt that there is a lot more that we could be doing if we set the incentives up correctly. So I'm kind of excited to see what else will happen there. And this is where independent living, active adult, low income seniors housing, places that aren't maybe
Middle income, I think it would
middle income.
send in middle income senior for sure.
There is a lot of interest in the population we call near duals,
Yeah. Yes.
meaning which means people who are not yet dually eligible for Medicare and Medicaid, but have relatively low income. And then the other thing that was explicit was, you know, uh, that they would be looking to foster models where the provider has the risk directly, as opposed to like what we might call enablers, sort of. Right. So, really, so this would be like the primary care organization, the hospital, the health system really being on the hook for that insurance risk, but having a lot more flexibility and tools, more like an insurance company than we've seen in the past. So, like the ability maybe to do prior authorization or the ability to pay for things that wouldn't otherwise be covered by Medicare. So, I think it's exciting to see what is coming down the pike. I think the senior living industry and all of its partners should be paying very close attention.
Yes.
Yeah, because there could be some incredible opportunities.
Yeah, it's something we want to stay on top of, and it's the we call it the Partnering for Health strategic initiative of our strategic plan, but it's it all of this stuff falls under that umbrella here. So we're going to continue to make sure we are partnering with experts like you and others in the industry that day to day have your eyes and ears to the ground with this. I do think it's an exciting time, and it's a little bit of time is now, or opportunity is now for this. So we
It's
are
not a moment too soon, right? The baby boomers just started turning 80. So we're just
I know. Yeah. It's a
gotta
little
get going.
little overwhelming, but it's exciting at the same
Yeah,
time.
I agree.
So any final comments as we wrap this up? I know we're about at time, but any final words of wisdom for our listeners?
I no, not really. I think like a huge kudos to you, Lisa, for your leadership and to NIC for the vision to be in the spot that you're in. It takes a lot of courage, I think, to be kind of um out in front on something that isn't necessarily as obvious to everybody as we would like it to be. And but I think it's gonna be very beneficial to the industry as these next few years unfold. So I'm really excited about the work you all are doing.
Well, thank you. And again, we appreciate partners like all of you. I mean, at the end of the day, it's, groups like you two are educating it to do the right thing. Because at the end of the day, all this boils down to what is the best in the best interest of the older adult, the senior or family and the workforce and so forth. So
Great.
well, thank you, Anne. I really appreciate your time with us. And thank you again to Sage for their sponsorship. So we encourage you to check out the other editions of the NIC Chats podcast. I can never say that one too many times quick. But appreciate all of you listening and thank you, Joy, for joining us here today, Anne.
Thank you.